I've included this table in your PowerPoints just as a visual representation for understanding your receptors and how they affect the different parts of your body, such as the cardiac effects, your peripheral vascular resistance, your arterial pressure, things of that nature. So make sure that you look at this. You don't have to certainly memorize it, but it does help for just a visual representation. What differentiates catecholamines regarding their hydroxyl groups and carbon position on the benzene ring is that the hydroxyl group is going to be in the 3rd and 4th position, and that's unique to catecholamines. This table is an important table to understand. What you need to notice is for one thing, your dosages. Do you need to memorize your dosages? You need to understand that your dopamine, the higher you go on that dose, the more you get those systemic effects as opposed to the renal vasodilation. You still get the renal vasodilation with those higher doses, but what you are shooting for when you increase that dopamine dose is the actual vasoconstriction and the increase in your heart rate and the facilitation of your cardiac contractility. Now, the higher the dose you go with any of these medications, the more likely you're to produce some dysrhythmic actions from the stimulation of those beta and receptors in your heart. But what is most important about this table is just getting an overall understanding. Do you need to know your doses? You do need to know your doses for your medications. You can write this table out, or you can just use it to help you to understand. But you do need to know that the highest you need to be going on your epinephrine is 20 mics a minute, because if you're over 20 mics a minute, then what do you need? You need a balloon pump for that patient, or an LVAD. Dobutamine, you shouldn't be going over 20 mics per kilo per minute, because that's an extreme dysrhythmogenic dose when you get over 20 mics, and you also increase that myocardial oxygen demand, that you're actually compromising that cardiac, your myocardium. So understand this table, and you can expect some questions on your exam regarding this table as well. Natural sympathomimetics that occur that are normally produced in the body, as you know or should know by now, is epinephrine, norepinephrine, and dopamine. This table is definitely important to understand regarding your organ systems and your receptors, agonism of your alpha versus your beta receptors and what they produce. With your eyes, your alpha agonist produces that mydriasis, which we've already discussed in your ophthalmic lecture. As far as the beta agonists go, there's no clinical relevance for whenever you stimulate those beta receptors. In the heart, we know that when you provide alpha agonism, it can cause a reflexive bradycardia from that baroreceptor response from tightening of those large vessels and the resulting bradycardia that occurs. When you stimulate those beta receptors in your cardiac muscle, you get tachycardia when you agonize those beta receptors. Contractility, alpha really has no issues on contractility or conduction velocity. There's no real relevance there, but with those betas, you get that increased contractility and increased conduction velocity. With that increase in contractility, and you get an increase in myocardial oxygen demand. Your blood vessels, your alpha agonist produces the vasoconstriction, which is why we love giving that phenylephrine. With beta agonists, you get vasodilation primarily to the skeletal muscles is what it's referring to the vasodilation. And that makes sense because when you get in that fight or flight response, you need blood supply to those skeletal muscles in order to fight. The lungs, the alphas really don't do anything, but definitely provides bronchodilation, so you can get all that oxygen to help supply those skeletal muscles that are increased perfusion to those skeletal muscles. You need that oxygen to be able to run, right, or to fight. As far as your GI tract goes, it's going to slow everything down, both those alphas and those betas, because you don't need any of that action going on. You're trying to conserve your energy as much as possible. You do need to note on the uterus as well, the alpha agonist produces contraction. Remember when you're going over your OB information regarding phenylephrine and ephedrine giving to mothers who have vasodilation with their spinal blockade. You can do small doses of alpha agonists, and the reason that they have approved, they've said you can give phenylephrine, but it has to be small doses, is because it does cause the placental insufficiency with high doses because it contracts that uterus, and that can result in metabolic acidosis of that fetus. With the beta agonists, you will actually relax that uterus and helps to increase perfusion to the fetus. So ephedrine is best, but you can use small doses of phenylephrine. And as far as the liver goes, both alpha and beta agonists will actually increase blood glucose. And we're going to get more into that into the lecture. Alpha and beta receptors respond very well to epinephrine. It depends on the presence of these receptors and just the number of those receptors as far as producing vascular tone. When you get a nice balance, you will get that alpha vasoconstriction as opposed to that beta vasodilation. So you will get an increase in your heart rate as well as vasoconstrictive effects in your vascular bed. One important thing to note in your vascular system is that you have quite a few alpha receptors in your venous system. So whenever you stimulate those and it produces the vasoconstriction, you will get a significant increase in your venous return. And you'll get an increase in your blood pressure from an increase in your chloride ions, and this produces an increase in your SVR. Now, when you're giving your epinephrine, when you increase your doses, you get more of an alpha-1 effect as opposed to your beta effects. So you can increase your afterload enough that you can actually impair your cardiac output. So you have to be very careful with balance. You're going to have tachycardia, especially whenever you start that epinephrine, and this can increase your blood pressure, and whenever your blood pressure increases, you can get that reflexive bradycardia. So you just have to keep an eye on your hemodynamics. Eventually, you can get that reflexive bradycardia, but the stimulation from the epinephrine is going to produce an overall tachycardia, especially with those higher doses. So keep an eye on your hemodynamics and make sure that you balance that epinephrine so that you get the vasoconstriction without too much of a tachycardic response. You will get renal vasoconstriction whenever you administer epinephrine. It's going to be about 2 to 10 times as potent as norepinephrine on renal vasculature. Epinephrine works on your beta-2 receptors. It will produce vasodilation primarily in that skeletal muscle, as we discussed earlier, but that vasodilation can cause a mild decrease in your blood pressure, but most people don't run a low enough dose of epinephrine to produce that vasodilation. Usually whenever you use an epinephrine, you're needing those increased doses to help with sustaining your hemodynamics. So typically in the clinical setting, you don't see those beta 2 effects as much as those beta 1s. So what does beta 1 do on your heart? Well, it increases your heart rate. How does it increase your heart rate? It accelerates your phase 4 depolarization. It definitely increases your conduction velocity, and it decreases your refractory period, which makes total sense with increasing that heart rate. It also increases your automaticity of your patients with those latent pacemakers. So you can actually get that increased heart rate with patients who are very slow in their conduction. Your myocardial contractility, as I've mentioned before, definitely increases, which can increase along with your heart rate, that myocardial oxygen supply, oxygen demand. Your increased heart rate and your increased contractility increase your demand, and your increased heart rate, if you're not providing enough filling time, may actually produce a decrease in supply. So you have to make sure that that's balanced out efficiently. Hopefully your increase in contractility and your increase in heart rate is going to lead to an increase in your cardiac output. And you're going to see an increase in your pulse pressure, and you should see an increase in your mean arterial pressure, because the goal of all of this is to raise your systemic blood pressure, and that's going to include your mean arterial pressure. So what does epi do to myocardial oxygen consumption? Well, as I've said on previous slides, it increases your left ventricular preload, because it increases your venous return rate. So it also increases contractility, it increases your afterload, and it produces tachycardia. So all of those things actually increase your oxygen, your myocardial oxygen demand or consumption. So is diastolic function improved with epinephrine? Absolutely. It increases myocardial relaxation rate, and that will actually enhance early left ventricular filling. So you can get an improvement in that diastolic function, but again, you have to make sure that it's not counterintuitive with tachycardia, to where that heart doesn't get time to fill. If you've got such a high dose that you've produced that tachycardia that is so quick that you do not have time to fill that ventricle, then you're going to be counterproductive for this function from epinephrine. Does epinephrine enhance coronary blood flow? If it's allowed to fill appropriately, if epinephrine is used correctly, it absolutely does enhance coronary blood flow. The arterial blood pressure may not change. You may be producing enough of a systemic balance that your blood pressure may not actually improve, but you're sustaining a rate that's high enough and filling pressures that are high enough that your coronary pressure will actually improve. So the right balance of epinephrine is what is necessary to produce these effects for everything to be improved upon, and this is on your compromised patient. Okay, so if you're overdosing with epinephrine, you're not going to obviously get these effects. You're going to be counterintuitive and counterproductive, and you're going to actually harm your patients. So you have to make sure whenever you're administering your epinephrine in the OR, because we don't have a doctor's order telling us what to do, we have to be very fluid in our actions and make sure that the dose that you're providing is the dose that the patient actually needs. Now, one thing I do want to mention is that patients that you see that have chronically elevated plasma epinephrine, pheochromocytomas, patients that abuse cocaine or methamphetamines that are constantly depleting those norepinephrine stores, those patients have a decrease in their intravascular plasma volume, because they have a decrease in their plasma proteins for several reasons that we have discussed in the past. Those cocaine abusers and methamphetamine abusers, as you know, have a lot of, especially when they're chronic abusers, they are malnourished, and they also have liver injuries. So that produces a decrease in those plasma proteins, which causes an inflammatory response. They leak that volume out, and then they've got this continuous elevation in their plasma epinephrine, and that causes localized inflammation for the arterial vasculature in the actual walls. They become damaged, and it can lead to actual necrosis, both of the vasculature, but primarily what you see is localized myocardial necrosis actually in the heart, and that's why you will find many of these patients with long-term drug use will have unknown myocardial infarcts. They can produce them from this necrosis, as well as they can have scattered areas of necrosis, and that produce such myocardial insufficiencies that they can actually over long term develop a cardiomyopathy that's drug related. Epinephrine works great on the airway for treating bronchospasm in small doses. It is your big gun that you take back whenever you're concerned about anybody that has a reactive airway, such as an asthmatic that you're concerned about, or a COPD patient, somebody that is high risk for bronchospasm. Epinephrine is your friend in small doses. Now, how does it work? It works on those beta 2 receptors in the lungs. It relaxes the smooth muscle by increasing the cyclic AMP. You will find patients that are on beta blockers that are prone for bronchospasm because it inhibits the relaxation of the smooth muscle through antagonizing the epinephrine. So you have to keep that in mind for patients that are on beta blockade, that they're at risk for bronchospasm. Your COPD patients, you don't want to give them beta blockade because of their risk for bronchospasm. It can actually make them symptomatic for several weeks after you give a single dose. So you have to be very careful with those patients. If you're giving high dose epinephrine, you can actually stimulate those alpha receptors. These can produce some terrible pulmonary hypertension, which will actually decrease the perfusion to the lungs. You've got a patient that's on beta blockade and you're giving them high dose epinephrine. You can actually stimulate bronchoconstriction with that, and your alpha agonism is not going to help you because of the vasoconstriction to the airway, in addition to the other effects. So you have to be very careful. Epinephrine is definitely your friend for the airway, but it is your friend for the airway in the small doses, as opposed to those 20 mics a minute doses. And this is just a picture for a visual understanding of a patient that has a normal airway, a patient that is an asthmatic, and then a patient in the OR who has an asthma attack that is a known asthmatic, and you can see how narrowed and restrictive that airway is. Epinephrine works on your beta 1 for liver glycogenolysis, as well as breakdown of that adipose tissue for lipolysis. So beta 1 definitely increases the breakdown to produce an increase in blood sugars. Alpha 1 actually inhibits the release of insulin, so you can have a combination of those two effects and can produce hyperglycemia. So you have to be careful on those diabetic patients because you will increase their plasma glucose, and those patients will be on insulin drips to help facilitate the decrease in the hyperglycemia. You'll also increase the plasma lactate levels from that skeletal muscle glycogenolysis that occurs. So your patients will become acidotic post-operatively if they're on epinephrine drips. You can just expect that. That also increases cholesterol, phospholipids, and those LDLs, but what we're worried about the most is the increase in those lactate levels in your plasma glucose and how to manage those appropriately. That's why you want to get your patient down on that epi as quickly as possible. And you know, I quit using epi on my patients and went to levo because it doesn't have as much of an effect as epi on your glucose and your lactate. Epinephrine actually works on the sodium-potassium pump in the skeletal muscles to drive the potassium into the cells, which can produce a perioperative hypokalemia and can cause some cardiac dysrhythmias both intra-op and post-operatively. So if your patient's on an epinephrine drip, you definitely need to be checking, or if you've utilized a lot of epinephrine with boluses throughout the case, or if you've resuscitated your patient, definitely be checking your potassium levels. And we've already discussed the eyeballs regarding mydriasis, and one thing, remember the contraction of the orbital muscles can produce an increase in your intraocular pressure, which can cause a slight projection of the eye outward from the globe, which will result in exophthalmos. As far as your GI and GU system, we know that epinephrine is going to relax that smooth muscle in the GI tract just like it does in the lungs. It does produce vasoconstriction of the renal and hepatosplenic circulation, which is going to divert that perfusion from those end organs to your skeletal muscles to facilitate that fight and flight response. It's going to slow your lactate clearance, so the patients at increased risk for lactic acidosis, and this is all dependent on the epidose. The higher you go, the more profound those responses can get. Your beta agonism relaxes the detrusor muscle, and I've got a slide following with a picture to help you to understand the location of your detrusor muscle and your trigone. Your alpha stimulation contracts that trigone and sphincter muscles to help to control your bladder. So here's a picture so you can see that detrusor muscle and that trigone area. With any initial stimulation, you're going to, of your sympathetic system, it gives you the sensation that you need to pee, but it's actually contracting of that sphincter so that you don't, and relaxing of that detrusor muscle so that your bladder can hold more volume. Epinephrine works on the coagulation cascade through stimulation of the alpha-2 and beta-3 receptors to induce platelet aggregation, and it also increases factor V activity. I think it's very interesting how epinephrine produces the vasoconstriction to help decrease blood loss, as well as primarily most importantly on those alpha-2s for inducing platelet aggregation in the body. So that's a double kudos to epinephrine to help decrease blood loss from the body. So moving on to norepinephrine, you know that it's synthesized and stored in those postganglionic sympathetic nervous system neural endings. So and I've included a picture here just for you guys understanding, and you know the precursor to norepinephrine is dopamine. We've gone through all of that. You've had that multiple times, so that should be well understood. Norepinephrine is equal to epinephrine for stimulation of beta-1 receptors. It will increase the heart rate, conduction, and contractility for the patient, which will increase that myocardial oxygen demand, right? Has minimal beta-2 effects, so that's a great thing to keep in mind whenever you don't want beta-2, but you do want that beta-1. It does produce fantastic alpha-1 for vasoconstriction for the arterial and venous bed, so it does help to increase your venous return, which will increase your stroke volume and your cardiac output. It does raise those PA pressures, so you have to consider that for patients with a history of pulmonary artery hypertension. It works more efficiently than epinephrine for your SVR increases and for your actual blood pressure, for increasing your diastolic, your systolic, and your mean arterial pressure. So it's great for increasing your blood pressure and increasing your stroke volume and cardiac output. The chronotropy is less than epinephrine, and it's less of an arrhythmogenic as compared to epinephrine, and it does not have the metabolic effects that epinephrine does at the typical doses. When you get into high doses, you can get some of those metabolic effects, but it's not as severe as with the high dose epinephrine. Hyperglycemia rarely occurs with norepinephrine, and you don't see that metabolic acidosis unless you get, again, into those real high doses of norepi. It does produce a loss of that proteins in the fluid, so you can get into long-term drips producing that vascular inflammatory process that we spoke about earlier with epinephrine, and those patients who have chronic release of those norepi stores. So norepinephrine is my preference over epinephrine for many cases, but again, epinephrine when you definitely need the all of the receptors agonized, then epi is would be chosen over norepinephrine. You mix norepi and D5 to prevent oxidation of those catecholamines. The dose is up to 16 mics a minute. Extravascation is bad news because it definitely causes tissue slough, can produce some terrible, terrible wounds that will need debridement. So use a central line preferably, or a very large peripheral IV, but again, a central line is definitely preferred. Do you need an arterial line? We as anesthesia providers, if we're hanging norepinephrine in the OR, then you really need an arterial line because you're hanging it for hemodynamic instability. You will find patients that are on this chronically on the floor that may have a non-invasive cuff measurement, but for us, we need an arterial line. That's what's best because we're starting it for a reason. Little norepinephrine is metabolized. It's actually taken back up into those adrenergic nerve endings. Norepinephrine is always the first line treatment for hypotension with severe sepsis. We know severe sepsis has an increase in that lactate level. They have terrible metabolic acidosis. And norepinephrine is best in because it decreases those effects as compared to epinephrine. It is used for coming off pump for patients with low SVR. I love coming off pump with norepi myself. You do have to be careful whenever you're using it for patients who have had bypass, because when you get into those high doses, you can compromise that coronary perfusion flow. You do have to be careful when you're utilizing norepinephrine in patients with heart failure on both right ventricular and left ventricular failure, because you get an increase in that SVR, but you also, remember, can have an increase in those PA pressures. So you have to consider that whenever you're utilizing it for patients with heart failure. You have to take into consideration their comorbidities and if that's the most appropriate medication for them. It does produce end organ hypoperfusion, so these patients can develop end organ failure, especially if they're on these drips for a considerable amount of time. Can you use it for patients with profound hypotension as long as you have adequate fluid resuscitation? Absolutely. You can use it and it will help improve the renal blood flow. But if you're using norepinephrine on patients who have bled out, then you're putting them at an increased risk for end organ failure and acute kidney injury. So you want to make sure that there is adequate resuscitation before you start norepinephrine in those patients. Dopamine is an old drug that's used quite a bit in the unit. You don't see it as much in the operating room unless they come down on a dopamine drip. Typically we utilize epi and norepi before we go to dopamine. You will see dopamine, some low-dose dopamine in some of your vascular cases, or sometimes you'll see it in the heart room. But again, the most recent literature doesn't support renal dose dopamine like it used to back in what I call the old days. But anyhow, your table from your previous slides provides the dosing on dopamine. Make sure that you use that in conjunction with your lecture to help understand it. It does regulate your cardiac, your vascular, and endocrine functions, as you know from your endocrine lectures. It does work on the central as well as the peripheral nervous system for receptor agonism. It does stimulate your dopaminergic and your adrenergic receptors, your D1, your D2, your alpha, and it also stimulates your beta receptors. Dopamine works on D1 and D2 receptors. It kind of works opposite on those receptors. With D1 is stimulation of the adenylate cyclase, and on D2 it inhibits the adenylate cyclase. So on D1, with the stimulation of it, it works postsynaptically to vasodilate the renal, mesenteric, coronary, and cerebral arteries, and it also inhibits that sodium-potassium adenosine triphosphatase. On the D2 receptors, it works presynaptically, and it inhibits that adenylate cyclase, which inhibits the release of norepinephrine, and that inhibition produces vasodilation. And that occurs in the pituitary gland, the emetic centers of the medulla, so that patient will actually have nausea and vomiting, and it works in the kidneys for vasodilation. Now, this is also the receptor, that D2, that works for the reward mechanism for patients that are utilizing cocaine and alcohol. If you've used dopamine in the ICU, if you've initiated that drip, then you know that every patient is different with how they respond. So it's very dose dependent with each individual, the patient that's on your table. Your renal dose dopamine usually is up to 3 mics per kilo per minute. That works on your D1 and D2 receptors for vasodilation. And that is vasodilation preferably to the renal vasculature. It can cause a decrease in the blood pressure, but typically it's not significant enough to cause any systemic effects. With that vasodilation, you get an increase in the vascular flow to the renal and splenic vessels, and the patient will hopefully produce some diuresis, some natriuresis, and you may actually see an increase in their heart rate with that diuresis, with a decrease in the intravascular volume. Now, the typical dose of dopamine is about 3 to 10 mics per kilo per minute, and that's going to stimulate your beta 1s and your alphas. It increases that norepinephrine release, so you can get an increase in your cardiac output, and you'll have that increased chronotropy, inotropy. You still get that vasodilation, especially to the in conjunction with that renal bed. You can still have some vasodilation there, as well as you can get a decrease in your afterload, so that will actually help to decrease the strain on your left ventricle. When you get above 10 mics per kilo per minute, you're primarily stimulating those alpha receptors. You still get those other receptors stimulated, but alpha is the one that is the strongest, which will produce your arterial and venous vasoconstriction. You'll get an increase in your SVR, your blood pressure will increase, and your cardiac output will increase, and you may actually see a reflexive bradycardia that increase in the blood pressure. So you have to stay on top of those dopamine drips to make sure that you don't develop too severe of a reflexive bradycardia, or that you make sure that you don't increase that blood pressure so much that the increase in the SVR and the increase in that blood pressure will cause an increase in your myocardial oxygen demand. So the dopamine is great, but when you get into those higher doses, you can actually get into some cardiac compromise, even though you do have an increase in your cardiac output. So as we stated, patients respond differently to dopamine, so you have to titrate it to the effect. The half-life's only about 2 minutes, so you definitely have to have a drip. You cannot be pushing dopamine in the OR. It's mixed in D5 because alkaline solutions will deactivate it. About 25% of dopamine is converted to norepinephrine, and norepinephrine is not metabolized. It's reuptaken into the adrenergic end receptors. So, or adrenergic end nerve endings. The other 75% is metabolized. It's conjugated in the liver to sulfates and glucuronides. It's also metabolized by COMT in your pulmonary vasculature endothelium, and then it's excreted by the kidneys. So you definitely need a drip. 25% of it's converted to norepi, and then it's metabolized in the liver, the lungs, and excreted in the kidneys. Dopamine does cause a dose-related sinus tachycardia. When you get into those high doses, if you've used dopamine very much, you know that it does produce tachycardia for sure, much more so than epi or dobutamine does. It does cause arrhythmias. It's very arrhythmogenic, especially as compared to epinephrine. It does predispose that patient to myocardial ischemia, as we've discussed already, and it does increase the risk for coronary artery vasospasm. The great thing about it is it doesn't inhibit pulmonary hypoxic pulmonary vasoconstriction, which it seems like everything else that we use in the OR does inhibit HPV. It's not recommended in patients with right heart failure. It does produce GI mucosal ischemia. If you've had patients on dopamine for long periods of time, they definitely can develop an ileus, and they can infarct their gut, and that increases the risk for bacterial toxins and even more multi-organ dysfunction. So you will see patients on dopamine with a decrease in gastric motility if they're on it for very long at all. And you know agonism of those receptors, both alpha and beta, decrease the gastric motility. Dopamine is also known to suppress those anterior pituitary hormones. It inhibits the thyrotropin-releasing hormone, which can produce a euthyroid 6 syndrome or central hypothyroidism. So that's something worthy of consideration for long-term effects. It can also cause a negative nitrogen balance in your patients because it produces growth hormone deficiencies. Again, those are more for long-term effects, something that we don't worry too much about in the operating room. One thing that we do need to definitely consider about dopamine is that it's an inhibitory neurotransmitter at the carotid bodies. And what it does, remember, dopamine can produce pulmonary artery hypertension. You don't want to use it in those right heart failure patients if you've got other medications that are more appropriate. The low-dose dopamine actually can interfere with ventilation from arterial hypoxemia and hypocapnia because it can impair that VQ mismatch in the lungs. So you can have patients that are on low-dose dopamine that can have these effects, as well as when you get into increasing those doses, you will increase that mismatch, and you will actually see a decrease in the PaO2 for these patients. So you need to be very careful with those right heart failure patients, as well as your patients who have a significant VQ mismatch to begin with. And any of the sympathomimetics are going to increase intraocular pressure, so make sure that you avoid dopamine in the glaucoma patient. So those were the natural sympathomimetics. Now we're going to move on to the synthetic sympathomimetics, your isoprel, your dobutamine, ephedrine, and phenylephrine. Isoprel is actually your most potent sympathomimetic. It works on your beta 1s and your beta 2s, and it's about 2 times as strong as epinephrine and about 100 times more strong than norepinephrine. You only use about 1 to 5 mics a minute, and that's used most commonly in heart block. If you use it, you need to make sure that it's mixed in D5 or normal saline. Don't stick it in any LR. It does increase chronotropy and inotropy. It can increase your inotropy significantly and increase that myocardial demand immediately. It's the cardiac pacemaker. It does increase your cardiac automaticity. It is a fantastic synthetic pacemaker. It does produce skeletal muscle vasodilation, so it can decrease your SVR and decrease your diastolic blood pressure, which your diastolic blood pressure or your coronary filling pressure, so it can decrease your coronary blood flow. So you have to keep that in mind, and it decreases your preload, which in effect will actually, if it's decreased significantly enough, can decrease your cardiac output. So what does this set a patient up with coronary artery disease for? An MI, right? Because of the increase in myocardial demand and decrease in coronary blood supply. So you have to be very careful with isoprel in a patient with known coronary artery disease. It's not used near as much as it used to. Typically, when I've used it, it's been up in the cath lab. It's whenever I've used it for my patients. It is rapidly metabolized by your COMT, so you do have to use a drip for this medication. Dobutamine is derived from isoprel. It's a 50-50 racemic mixture of 2 isomers that are mirror images. Your negative enantiomer is a very potent alpha agonist, and it's a weak beta agonist, and then your positive enantiomer is actually a competitive antagonist at the alpha site. So it will actually block those alpha receptors, which at high doses will cause venous dilation. Your potent beta agonism of that positive enantiomer will stimulate the SA and AV node for automaticity, so it will increase your heart rate. Dobutamine is a positive inotrope. We use it a lot. I've used it most often in the heart room with my valvular disease patients, and in the I've used it in the vascular room for patients because of my renal failure patients that come in with heart failure. Anyhow, so you use it most commonly in heart failure patients and whenever you're weaning from cardiopulmonary bypass. And you'll also see the dobutamine stress test done up in the cath lab in the cardiac diagnostic centers. It increases your cyclic AMP, which increases your calcium release from your sarcoplasmic reticulum, which will increase your contractility. Your cardiac output increases because you do have an increase in your stroke volume with that increase in your contractility, and that's from your beta 1s and your alpha 1s. And then you have peripheral vasodilation from your beta 2 agonism. So you get set up to dobutamine sets your patient up for success through those measures for increasing their cardiac output. Your drips, typically 2 to 10 mics per kilo per minute. Your beta receptors will actually produce tachyphylaxis with continued use of this drip. So they do try to get the patient off this drip as soon as possible. Again, it's mixed in D5. Alkaline solutions are typically bad news for all of these sympathomimetics. There is biotransformation in the liver where it's conjugated into inactive glucuronide conjugates and 3,0-methyldobutamine, which is important to know for boards. It's primarily excreted in the urine. So you need patients who are excreting urine, or you will have patients who are on dialysis that may be on this medication. Side effects are tachycardia. You'll see that primarily with your higher doses. You can have patients who develop eosinophilic myocarditis, which is interesting. I've never seen that, or the peripheral eosinophilia. I've really not seen that much that has been linked back to the dobutamine, but that is in the literature, and it is important side effects to understand. I have seen the tachycardia. At high doses, dobutamine does increase myocardial oxygen demands. It decreases myocardial oxygen demands if contractility is greatly improved and the left ventricular end diastolic pressures decreased with decreased wall tension. So that's when the myocardial oxygen demand is decreased. But if you do not have those effects produced, then you'll actually have an increase in your myocardial oxygen demands from this strip. It does decrease sympathetic nervous system tone, which will help with that forward flow. It decreases your PA pressures, which are your beta 2 receptors, and that's good for those heart failure patients. Your mitral valve repair patients or your replacement patients, they will be on these drips many times, and it's all to facilitate increasing their cardiac output to decrease their PA pressures and to decrease their systemic pressures. So it's a good drug to utilize in the heart room whenever you've got valve repairs going on. It does inhibit your HPV, so you can see alterations in your VQ mismatch. It does increase pulmonary shunting, so that you will be in conjunction with your inhibition of your HPV. It doesn't stimulate release of endogenous norepinephrine, and it does not increase renal blood flow. It can increase renal blood flow indirectly when it increases cardiac output, but it doesn't as far as directly altering that renal or that renal splenic blood flow. It doesn't directly do it. It's indirectly through an increase in your cardiac output. And again, here's the table for a quick reference. Ephedrine is an indirect acting sympathomimetic. It's partially direct stimulation because it does directly stimulate as well as it helps to release the endogenous norepinephrine stores that's in those nerve endings. So you get it's direct and indirect as far as the sympathomimetic effects go. 40% of it is excreted in the urine unchanged. It does stimulate alpha and beta. Does not cause the hyperglycemia that you see with the epinephrine, the direct acting stimulation from epinephrine. It does cause mydriasis, so you have to consider that for those patients with an increase in intraocular pressure. It does cause central nervous system stimulation, but less so than amphetamines. And whenever you've got a patient that has chronic amphetamine use, you know that they deplete those norepinephrine stores, and so whenever those patients come in, your ephedrine is not going to be as reactive as the direct acting CNS stimulants such as your epinephrine. So if you get somebody who comes in that is using cocaine or amphetamines, know that their norepi stores are depleted, so you're going to have to switch from your ephedrine to your direct acting epinephrine. Typically, we give 5 to 10 milligram IV boluses in the OR. It increases the blood pressure when the sympathetic nervous system is blocked by anesthesia, such as with your spinals or with any of your neuraxial anesthesia. It is the sympathetic stimulant of choice for parturients. As I've mentioned before, phenylephrine is associated with a higher umbilical artery pH, and so you will actually utilize your ephedrine much more so than you will your phenylephrine down in labor and delivery. It treats acute coryza, chronic oral medications, your bronchial asthma treatments, which are your beta-2 stimulants that you provide for your asthmatic patients. Those patients may need your direct acting sympathomimetics as compared to your ephedrine. If you're going to give ephedrine IM, you typically give 0.5 milligrams per kilogram. This can produce antiemetic effects that are similar to droperidol but can produce less sedation. You just have to make sure that you warn your PACU nurse that the patient may have a little bit of tachycardia whenever you give that IM ephedrine, because they do absorb that and have those systemic effects. The systemic effects for your blood pressure are less than that of epinephrine, but it will actually last 10 times longer than epinephrine. The duration is improved as compared to epinephrine, but you will definitely see patients develop tachyphylaxis when you're utilizing this medication for a long case. So you have to keep that in mind, and you'll be increasing your dose, but you will still have that longer duration of effect. Phenylephrine is much like norepinephrine as compared to epinephrine. It's less potent, but it lasts longer. It differs structurally from epinephrine only because it lacks a 4-hydroxyl group on the benzene ring. Phenylephrine is a very strong alpha stimulator. It works more on alpha 1s as compared to alpha 2. Even though it can work out on alpha 2, it needs those larger doses of phenylephrine to do so. It does weakly stimulate the release of norepinephrine. That's again with those larger doses. It has very minimal effect on betas. So what you get is great vascular constriction, with your venous constriction much greater than your arterial constriction, even though what we typically see, what we're looking for, is that arterial constriction in the OR. But know that that venous constriction is greater than your arterial, and you will actually get quite a bit of increase in your venous return, which will help with that cardiac output, which will raise your blood pressure, as well as the arterial constriction. Typically, we give anywhere between 50 and 200 mics IV push in the OR. I have given as low as 25 mics whenever I've had somebody who's very, very dry and extremely labile. So it's all dependent on the patient that's on your table. I've utilized it. You can utilize it whenever you've got that sympathetic nervous system blockade, like with your spinals and your epidurals. It's good for patients with coronary artery disease or aortic stenosis, provided that you don't overtreat and produce a hypertension in those patients. It's good when used appropriately because it increases your coronary perfusion pressures. It increases that diastolic pressure. There's minimal, if any, increase in your chronotropy, so you don't have to worry about tachycardia along with an increase in your blood pressure. So that's good. Actually, you will have a reflexive decrease in your heart rate if the patient is really low in their blood pressure. When you give a rapid high dose push, your coronary artery disease patient can have a decrease in their left ventricular global function, but that's very transient. So be careful about giving those high doses quickly. You want to give it in an appropriate amount. You don't want to respond reflexively and overtreat these patients. It can be utilized as a drip. You just mix it in some normal saline, or you can be pushed, as I said earlier, and it does slow. It does produce that reflexive vagal response, which will slow the heart rate, and you can use it actually to slow a patient down that's in SVT if they're hypotensive. You can give it, and they will actually decrease their heart rate down, and they may even convert out of it. It's not the first drug of choice for treating SVT, but it is if you're in the OR and the patient pops into an SVT and they become hypotensive because they're not feeling. You can give phenylephrine and see if you can't slow it down. If you're running a drip, it's usually 20 to 100 mics a minute. And this is also, phenylephrine is also utilized by us in anesthesia in the OR, or actually in the holding area, as a nasal spray whenever you're preparing these patients that are having a nasal intubation. They'll utilize a 1% concentration spray for prep. You may also see phenylephrine used in the ENT room whenever they're doing sinus surgery, and that needs to always be at the forefront of your brain whenever you're in the ENT room, because anytime you're doing anything in the nose and you're using any of the vasoconstrictors, whether it's phenylephrine or if it's cocaine or whatever is the drug of choice that is being used, you need to make sure and remember how that affects your arterial bed, and especially with those patients with heart failure, or if you're going to be given beta blockers, you don't want to beta relax with a strong alpha constriction because of the risk for developing pulmonary edema. Phenylephrine does decrease the renal, splenic, and cutaneous blood flow, but it does increase the coronary blood flow. It increases that diastolic pressure, which is your filling pressures. Your PA pressures are increased, so you have to be careful with those heart failure patients, especially whenever you're giving your larger doses. If you've got a potassium drip going and you push your neosynephrine, or if you hang a drip, you have to remember that it's going to prevent potassium movement into the cell. So your phenylephrine is an alpha agonist, so its effect on potassium is opposite of your beta-2 agonistic effects on potassium. So that has to be kept in mind. It doesn't interfere with potassium transport in the absence of a drip. When it interferes is whenever you're giving those pushes very frequently, or if you actually have a drip that's infusing. So you have to make sure that you keep that in mind, because if you get a low serum potassium level, then you're at risk for cardiac dysrhythmias. And as mentioned earlier, phenylephrine is used quite frequently in the ENT room. It can cause that systemic hypertension. These guys will soak pledgets in phenylephrine, and then they'll stuff them up the nose, and that will cause your patient to become hypertensive. So you have to pay attention to what your ENT doctors are doing whenever they're working on the sinuses. The patient can develop a reflexive bradycardia from the systemic hypertension that is produced by these large amounts of phenylephrine that's stuck up the nose. So just be diligent whenever you're in the T room, and make sure that you're keeping an eye on that. You can always treat it with phentolamine, which nobody has phentolamine in the OR unless you specifically ask for it. But we frequently have nitroglycerin or nipride available. Remember, you don't want to be using beta blockers if you're going to be using high-dose phenylephrine because of the risk for pulmonary edema. Moving on from your alpha agonist to your beta 2 agonist, these are your albuterol, your metoprolol, and your terbutaline. These relax smooth muscle in your airways, your bronchioles, and your uterus. It does stimulate beta 1 when you use high doses. There's no such thing as beta selective when it comes to high dosing of anything. You're going to get some of those other receptors. So what do we use beta 2 agonists for? Typically it's used for those asthmatic patients that have acute asthma attacks. It's also used for preventing exercise-induced asthma. It's used for treating COPD patients, and then it's also utilized in labor and delivery as a tocolytic. So you can give it oral, inhaled, sub-Q, or IV. Your side effects are the least with the inhaled route, because only about 12% of the drug is actually delivered with those meter dose inhalers. And when you have an ET tube in place, you can cut that in half by you can decrease that dose by half to 70%. So you really need to give about 6 to 10 times what a typical patient that's awake and inhaling would use whenever you've got a patient that's intubated to produce that bronchodilation. And this is just another visual representation to help you understand those hydroxyl groups on that benzene ring. The worst side effects that you're going to see for those beta 2 agonists have a tendency to be worse for systemic administration as compared to the inhaled administration, and that makes sense, seeing that inhaled is much less effective as compared to the systemic. Tremors are the most common side effect that you will see, especially with repeated dosing, and that's because of the direct stimulation of those beta 2 skeletal muscle receptors. You can also see hypotension, and that will produce an increase in the chronotropy. You will see direct beta 2 stimulation in the heart. They can produce hyperglycemia, hypokalemia, hypomagnesemia. These patients may experience lactic acidosis because of the lysis of the glucose and the fat and the adiposin in the liver. So you see that with those beta 2 agonists, as we've discussed previously. Now, keeping in mind that the inhaled is much less as compared to the systemic administration, but you still, with repeated doses, especially when you're giving multiple repeated doses, you can see these effects. Albuterol is the beta 2 agonist that we see the most, that we use the most in the OR. It is preferred for acute bronchospasm. It is the rescue inhalers that these asthmatics will carry around. The metered dose gives about 100 mics per puff. Usually people will use 1 to 2 puffs and generally don't require more than about 16 to 20 puffs a day whenever they're using it. And you definitely need to know how often they're using it or if they've recently used it before you get these patients off to sleep. A neb dose is 0.5 to 1 cc's of a 0.5% solution. You mix it in 5 cc's of normal saline and administer that every 15 minutes times 4 doses for an acute bronchospasm, and then they can have treatments every hour. Typically it lasts about 4 hours. Patients have been known to remain symptom-free for up to 8 hours, but again, you may end up giving multiple doses to relieve that bronchospasm, or I've even had patients who had to have a continuous neb in the recovery room until they were able to be weaned from that continuous neb and go on into Q1 to Q4 hour dosing. And whenever you have a continuous nebulizer, it's usually at 15 milligrams per hour. You can have more, but that's generally about the dose that you get. And so you can definitely get into those systemic responses with that high dosing, and you can get into some beta 1 activity. You will see tachycardia with the increased doses of albuterol. Metoprolol is delivered through a meter dose inhaler. It's about 630 mics per puff. Typically, patients don't take more than about 16 puffs a day. And it's excreted, interestingly enough, as conjugated glucuronic acid renally. Terbutaline is also a beta-2 agonist. I've actually given terbutaline sub-Q. It can be given oral sub-Q or as an inhalation agent for asthmatics. 0.25 milligrams sub-Q is similar to a dose of epi, but it has a longer duration. Kids, the dose is 0.01 milligrams per kilogram. Whenever you're giving an adult a meter dose inhaler, it's about 200 mics a puff. And again, it's pretty easy to remember these inhalers are 16 typically puffs per day, never more than 20. If patients report that they're taking more than 20 puffs a day, they need to be reevaluated by their pulmonologist. Digoxin is an old drug. It is a cardiac glycoside. It's actually derived from the herb foxglove. People back in the primitive settlers' days used to chew foxglove whenever they had chest pain or shortness of breath. And it's actually a decent inotrope. We typically use it anymore for dysrhythmias associated with a rapid ventricular response. You'll see it given to patients that have a history of SVT, AFib, or flutter. It does slow that conduction through the AV node. Now, it does increase contractility, but the question is, do we use DIG for treatment for left ventricular contractility dysfunction? Is this a first-line treatment medication? And the answer is no, not anymore. It's not first line because we have so many other drugs that are much better as compared to digoxin. And digoxin has some pretty significant side effects, and it has a high toxicity level. So we have a tendency to use the newer drugs more often. Now, you will see it still come around on patients, especially those patients with congestive heart failure, but it is typically added to other drugs just to help with that contractility and to slow that AV node conduction. So it does decrease overall mortality for these patients that have just terrible systemic effects from their heart failure, but it is not a first-line treatment anymore. So you might actually utilize digoxin in the OR if the patient goes into an SVT. There's other medications that you can give. Typically what we end up grabbing whenever patients go into SVT is, depending on what's going on, what we have most often in our drug box is Esmolol. We'll give some Esmolol to try to convert it quickly, and then you can also cardiovert the patient, but if you're going to use digoxin, you don't want to use it in addition to the cardioversion because you can put the patient into VFib. So if your patient goes into SVT in the OR, typically what we do is we grab the Esmolol and call for the defibrillator, and we give the Esmolol to see if it will convert the patient, and then we cardiovert them. But if you have DIG in the OR, you can give digoxin. But once you give that DIG, then you're going to want to get a cardiac consult before you start defibrillating. So most of the time, what you're going to see, again, in the OR is Esmolol being given and cardioversion. If you have propranolol, you can give it, but those patients will be cardioverted before you actually get DIG, because most people don't keep DIG in the OR routinely. Some of the larger academic centers that have every drug known to man in the drawers will have it, but please keep in mind that you can put the patient into VFib with DIG and cardioversion combined. All right, so If a patient has a history of Wolff-Parkinson-White and they go into their tachycardia in the OR, you give DIG. It's going to block that atrial firing and produce ventricular fibrillation. So you want to avoid DIG for Wolff-Parkinson-White in the OR as well. And those are two things that you definitely want to keep in the front of your brain when it comes to digoxin and utilization in the OR for SVT. Now, patients with idiopathic hypertrophic subaortic stenosis, IHSS, digoxin will increase the contractility of the heart, and what that will do is it will actually increase the obstruction. So it will impair the ventricular outflow. So in your IHSS patients, you don't want to give digoxin because it will cause that subaortic stenosis to become even worse. Patients who come in that are on oral digoxin, you need to make sure that you understand when their last dose was, because onset's in about a half an hour to 2 hours. The peak is about in 1 to 3, and as far as the peak plasma concentration, the peak effect is actually 6 hours post-ingestion. Your IV dose is 100% bioavailable. The peak plasma concentration is immediate, and the onset's within about 10 to 30 minutes, and then the peak effects 2 to 4 hours. So you're going to get the best effects significantly longer after it's been administered, but you should have an immediate effect. Half-life's about 1 to 2 days, which is pretty significant, especially if the patient's on their PO dose. It is renally excreted, so those patients that have a low GFR will actually increase their digoxin plasma level in their circulation. So you have to be really careful and give a smaller dose for those patients with renal impairment. DIG's mechanism of action is direct and indirect. The indirect effects are actually reflexive with some bradycardia. It causes that autonomic nervous system to have some vasoconstriction and reflexive bradycardia, and we're going to talk more about that with the next slide. But its direct effects are in actually inhibiting the export of sodium from intracellular containment. So when that sodium is blocked, it also prevents calcium from leaving the cell, so you will actually have an increase in intracellular calcium, and that's the direct physiological action of the digoxin on the cardiac myocytes. DIG is a dose-dependent inotrope. It does increase the stroke volume, which is fantastic for your heart failure patients, especially those that have some LV dilatation, because it shifts the Frank-Starling curve to the left, which can actually produce a double increase in the stroke volume for heart failure patients. The left ventricular end diastolic pressure is actually decreased with this increase in stroke volume. The heart size will decrease, and the patients have an increase in their cardiac output. They have an increase in their renal perfusion, and so they will actually diurese, which will decrease that preload, which can actually help with that LV dilation and RV dilation. So you get some significant effects for your heart failure patients, even though it's not a first-line defense for patients anymore for dysrhythmias. That you will see some of these, especially these renal patients, on digoxin. But again, it may be a low dose, and it's not the first line drug that they immediately go to. All right, so those reflexive indirect effects that we talked about causes a decrease in the SVR. It actually blocks the normal increase in the sympathetic nervous system that increases the SVR, so your SVR is decreased. Whenever you give DIG to a normal heart, the cardiac output may be unchanged or decreased, and the reason that it's unchanged or decreased is if you get those parasympathetic responses, that reflexive bradycardia that can occur as a result of that vasoconstriction. Now, if you get the parasympathetic stimulation that produces bradycardia, and you don't have the vasoconstriction, then you're going to have a decrease in the cardiac output. But if you get vasoconstriction along with that bradycardia, or if you get vasoconstriction and then a reflexive bradycardia, then your cardiac output may be unchanged. Now, digoxin is a cardiac glycoside, and we need to talk about cardiac glycosides and their effects on the EKG. They can prolong the P to R, which can produce a complete heart block. You don't want to give these patients DIG that have delayed impulses through that AV node. You can see atrial tachycardia with DIG toxicity. That's actually the most common dysrhythmia that you'll see with DIG toxicity. And DIG, as you know, has a very narrow therapeutic index, so they will be getting digoxin levels, and the patients are educated on the symptoms of DIG toxicity. The patient may also experience a shortened QT, which can cause a more rapid ventricular repolarization time. They may have some ST depression to where they will have a scaffold or what looks like a scooped out ST slope, and that produces a decreased slope in phase 3 depolarization of those cardiac action potentials on your action potential waveform. You can have a diminished or inverted T wave, and actually that's probably the most common thing that you see with DIG is those T wave alterations. Your ST segment and T wave don't necessarily correlate with therapeutic plasma concentrations. So it's not an indicator, but what you'll find is when patients do have those alterations, they will be getting DIG levels ordered. The ST segment and the T wave can suggest myocardial ischemia, of course, as in any other EKG. So you do want to make sure that the patients are monitored with their EKGs, they're trended appropriately, and any indication for ischemia is worked up. Now, what you'll see is whenever those patients go off those cardiac glycosides, they DC their DIG. That takes several weeks for those changes on the EKG to actually disappear. So that's something to keep in mind whenever patients come in preoperatively and they have held their DIG. You have to still evaluate those EKGs, and they may have the no change from, they may still have that scooped out ST segment that has been experienced with their digoxin treatment protocol. DIG toxicity occurs at greater than 3 nanograms per milliliter. It mimics cardiac disease, and you can see why based on the changes that are experienced with that EKG. The plasma concentrations have to be decreased to less than 0.5 nanograms per milliliter to eliminate all of the DIG toxicity for those effects to resolve. The DIG toxicity is very common in renal failure. It's common in patients that are receiving potassium depleting diuretics because hypokalemia increases that myocardial binding of digoxin and increases the drug effect. So you can have a couple of big whammies with your patient whenever they are renal failure and then they've been dialyzed and they're actually on the low side of their potassium level. So you have to keep that in mind whenever you're dosing DIG on those patients. DIG toxicity is common with hypercalcemia, with low magnesium, and it can occur with arterial hypoxemia. So what do we need to do to manage these patients most efficiently is make sure that our dosing is appropriate, and we need to make sure that the patient's adequately oxygenated. We want to avoid hypercalcemia, treat hypomagnesemia whenever these patients are on digoxin. We want to decrease their PaCO2, and why? Because for every 10 millimeters of mercury that we decrease that PaCO2, we're going to actually decrease the potassium by 0.5 milliequivalents per liter. So you want to keep them at a normal level, but you don't want to deplete them because hypokalemia increases that myocardial binding. So you don't want hyperkalemia because of the cardiac irritability that can occur, but you don't want hypokalemia because of the digitoxicity that can occur. So you want to make sure that these patients are kept as close to their normal as possible. So what are the treatment methods whenever digitoxicity exists? Well, you need to make sure that you fix what's causing it, which may be too high of a dose of dig. You might want to correct the low potassium, the low magnesium. If the patient's hypoxic, you definitely want to take care of that. You can administer dilantin, lidocaine, and atropine. For dilantin, of course, these patients can have seizures with that digitoxicity. If they start seeing those halos, you definitely need to make sure and treat them. As far as lidocaine and atropine, those are definite for cardiac dysrhythmias. You may have to transcutaneously pace them, or you may have to insert a temporary cardiac pacemaker if they go into complete heart block. You need to administer potassium to replace those patients who are hypokalemic. You might end up giving 0.025 to 0.05 milliequivalents per kilo for life-threatening dysrhythmias that is given IV. Over about 20 minutes, you can give lidocaine 1 to 2 milligrams per kilogram for your ventricular dysrhythmias. You can also give 0.5 to 1.5 milligrams per kilogram of dilantin IV over 5 minutes for those dysrhythmias as well. And again, these patients, when they get severe digitoxicity, they'll go into cardiac dysrhythmias, seize and arrest completely. Atropine, 35 to 75 mics per kilo, IV push for bradycardia, and those are pretty significant for treating digitoxicity. Hopefully your patient won't be anywhere near that. What medications alter digoxin? Quinidine increases digoxin. Sux can increase the dysrhythmias that are associated in combination with digoxin. All of your sympathomimetics and IV calcium can increase your dysrhythmias because of the effects that we've already discussed. Any drug that can cause hypokalemia can cause digitoxicity and can prolong the effects of the digoxin. Oral antacids and oral digoxin have oral antacids giving with oral digoxin decreases the absorption of the oral digoxin, and as you know, oral digoxin has a decreased absorption as compared to your IV digoxin, which is immediate effects. Your isofentanyl and fluorane all protect those dig-enhanced cardiac automaticity, so those medications will actually help. So now we're going to shift gears to selective phosphodiesterase inhibitors. You'll see them listed as PDE3s. These medications are amrinone, milrinone. Milrinone is probably the most common one that you're going to see in the OR that is administered, and that is given pretty frequently in the heart room, especially in those valve repairs. It is a competitive inhibitor of the phosphodiesterase enzymes. They are inodilators, which means that they have positive inotropic effects, and they relax the smooth muscle of the vasculature. So they will produce some pretty profound hypotension. They do increase the contractility, the cardiac output. They will decrease that left ventricular end diastolic pressure because you do get a decrease in the venous return, but you get an increase in contractility, which helps to increase that cardiac output. You do have an increase in venous capacitance. Those veins are dilated and they will hold more volume. You will get a decrease in those filling pressures, your CVP and your wedge, and a decreased venous return, as I had mentioned. Your phosphodiesterase inhibitors decrease your preload, and they also decrease your afterload. They will decrease your mean arterial pressure. Your text says some. That is dose dependent. It decrease your heart rate a little bit, but it's a definite inotrope. So you're going to get some good contraction, and your cardiac output will go up. Your myocardial oxygen demand will decrease based on the decrease in that wall tension, because you've decreased your preload and your afterload. Even though you increase your contractility, that decrease, it's counterbalanced by that decrease in that wall tension. So your myocardial oxygen demand will improve. Your oxygen consumption is always dependent on your heart rate, your contractility, and your ventricular wall tension. And all of those are decreased with your phosphodiesterase inhibitors. So you are definitely benefiting that myocardium with administration of your phosphodiesterase inhibitors. Your catecholamine effects are enhanced, so you will see a more sensitive patient to your epinephrine or your levo, so you have to keep that in mind and be careful with your dosing. These patients that are getting these inotrope and medications such as milrinone, they really need inotropic therapy for the contractility, but they also need that vasodilation because their heart just cannot push against a contracted system. It really stresses the heart. So that's the patients that you're going to see these phosphodiesterase inhibitors used on. So with amrinone, it's dose dependent. All these are dose dependent, milrinone and amrinone. You get a dose dependent inotropin vasodilator that can be given oral or IV. It increases your cardiac output, your cardiac index, it increases your stroke index, increases your ejection fraction, and then it decreases those pressures we talked about as it increases your contractility. So, and with minimal change on the heart rate, it's a fantastic drug for those hearts that just cannot tolerate that ventricular wall stretching. If you're giving it IV, you're going to give a bolus dose of 0.5 to 1.5 milligrams per kilogram, and then you're going to run the drip about 2 to 10 mics per kilo per minute for maintenance. The patients typically can only get about 10 milligrams per kilogram, including their bolus, in a day, and that's just because it causes such vasodilation. So you have to be really careful with balancing that out. It is pretty immediate with an increase in your cardiac output in about 5 minutes, and it typically lasts around 2 hours. Now, you do get tachyphylaxis, so you have to be careful with not exceeding that 10 milligram per kilogram dose in 24 hours. Patients with renal disease, because this is excreted renally, they need to have a decreased dose. The side effects, hypotension is the most profound that you see with these phosphodiesterase inhibitors, so much so that you may end up giving a slight bit of phenylephrine to help support the pressure for these patients if they have severe enough cardiac disease. And then you can develop thrombocytopenia, but that's usually with those patients who are on long-term oral therapy, and you can develop cardiac dysrhythmias with this. Typically, whenever these patients come in their own amrinone PO at home, when they come in, we'll actually put them on milrinone to manage them intraoperatively if they need to be dosed. Again, you typically don't see this medication unless it's somebody coming from the ICU, or if you're in the heart room. Or, you know, whenever you get traumas in or something like that, you may end up starting milrinone on those patients because of their cardiac dysfunction. But typically, this is a medication that you'll see most often in the cath lab and in the heart room itself. Milrinone is actually a derivative of amrinone. It's 30 times more potent as far as the inotropy of amrinone, and it has less adverse effects, which is why this is the drug that you're going to see in the clinical setting. If you did an amrinone infusion in the hospital, it would surprise me. Milrinone I've used many times. It's fantastic for dosing for the patient. You're going to learn all about that whenever you're coming off pump with these valve repairs. You'll learn about that in the fall. But what you need to understand is that it's 30 times more potent than amrinone. It has less adverse effects. You can give 50 mics per kilo bolus over 10 minutes. Many times in the heart room we'll end up giving much less than that because of the profound hypotension that can occur with that dose. But that's the dose that Stolting suggests excuse me, for your bolus. Now your infusion rate is going to be 0.375 to 0.75 mics per kilo per minute. And that's about where you run those patients when they end up on drips. Now, many times you'll dose the patient in the OR and then a drip won't be started until they get to the unit. The most important thing to remember is your bolus dosing and your max daily dose of 1.3 milligrams per kilogram per day. And again, you get these max doses. Seldom will you actually administer that max dose as an anesthetist. Just because you get such profound hypotension from this medication. It is 70% protein bound, which means if you've got these little geriatric patients or these liver patients that are have hypoalbuminemia, then you're going to need to decrease their dose. The half-life's about 2.7 hours, so whenever you dose it, you know you've got a good 2 hours in the OR, going from the OR up to the unit. So you're pretty good with not getting that drip started right away if it's not necessary. It is excreted 80% in the kidneys unchanged, which is why if you've got a renal patient, then you need to decrease your dose. And then what is metabolized is through glucuronide conjugation before it's excreted. So who do you use your milrinone on? It's typically for that patient with acute left ventricular dysfunction. And that patient is the one that you will use it on in the general OR. Now, on those patients who have left ventricular dysfunction that are having their valves repaired, I love milrinone on those patients. They do very well weaning from cardiopulmonary bypass. You'll learn more about the details of that. You give it prior to the clamp coming off in the heart room. That's not anything to be worried about this time, but just know that it's utilized for patients with acute LV dysfunction, and then it's very commonly used for weaning from cardiopulmonary bypass. You will use it for pulmonary hypertension patients because it does decrease those PA pressures, and because you've got that forward flow now. It's very conducive to forward flow in the heart and through the lungs. And then you may see it for a bridge to heart transplant for those patients. They'll be on amrinone out in the community, and then they'll come in and be placed on milrinone prior to being taken to the OR for their transplant. Again, hypotension is the most common side effect. It decreases your SVR, decreases your venous return, which is great for the heart, but it isn't great for perfusion to the noggin, to your cranium. So you need to make sure that the patient's blood pressure still stays within a normal range, which may mean augmenting that with a little bit of phenylephrine just to constrict that arterial and venous bed enough that the brain is being perfused adequately. It's not for chronic management of severe CHF because it does increase the risk for cardiac dysrhythmias, which increases the risk for an unwitnessed arrest out in the community. So these patients will have an increase in their morbidity and mortality with severe CHF. So you use it in the heart room with these patients, but they have to be stabilized before you can actually use it in the heart room. And you're not going to take a patient to the heart room that's in severe CHF to begin with. You may see those patients in the OR for emergency surgeries, but typically the cardiac patients are going to be optimized as much as possible, which may mean being in the ICU for a week being managed before they actually present to you for anesthesia. Calcium is another element to be discussed for sympathomimetics. You need to make sure and remember your levels. Your calcium is usually, around 10 is what Stolting said. Nagelhout. Stolting has listed, 4.3 to 5.3 milliequivalents per liter. That converts to around 10 milligrams per deciliter, which is what it's typically measured in the serum whenever you get your labs drawn. Your ionized calcium is around 4 to 5 milligrams per deciliter. I don't want you memorizing how many milliequivalents per liter, but I do want you to understand that calcium increases that inotrope of the heart and increases the venous and arterial constriction. It will actually help to improve your blood pressure whenever you administer calcium intraoperatively. We have medications that are considered to be like a novel class of inotropes that will increase the contractility. And how they do that is by making the myocardium more sensitive to calcium. And one of those drugs that you may see used in the OR is the levosimendan. All right, levosimendan. Anyhow, however you pronounce it, it treats cardiac shock because it sensitizes that myocardium to the calcium. So it increases the contractility of the heart. So it's a positive inotrope. It also activates your adenosine triphosphate regulated potassium channels, which will produce vasodilation, and that will help protect that myocardium because it decreases the resistance that it's pushing against. So you can actually have an increase in your cardiac output, and your SVR will decrease and your PVR will decrease. So it's very good for patients that come in cardiogenic shock. I myself have never used it, but maybe some of you guys have used it or seen it used in the ICU. Typically, whenever I've seen cardiogenic shock, it's required the chest to get cracked. So the patients that have come in looking like death on a cracker to me have gone straight to a balloon pump to epi and norepi, phenylephrine, cracked chest, and repairs. Bypass. Bypass is the answer for me in the OR, but for testing purposes, you need to know this slide. So have fun with this, and good luck.